Good afternoon and good morning to those of you calling from other parts of the country. My name is Patty Hyde, and I'm the Director of Clinical and Regulatory Affairs for the Home Care Association of Florida, and I'd like to thank you for joining us for this event, which is being offered in partnership with the Home Care Associations from the states of Arizona, Nebraska, and Massachusetts. Before we begin, we'll go through the usual housekeeping items. First off, we are recording today's webinar, so if you'd like to recommend this program to your colleagues, as you know, we appreciate that. So it will be available for purchase in the near future through the association you registered through and also on our e-learning website at www.homecarelearn.com. Handouts were contained in the login instruction email you received from your association, but in case you cannot locate those handouts, just know you can access them now through your GoToWebinar console located under the heading Handouts. Participant phone lines have been muted and will continue to be muted during the presentation to help minimize background noise. However, for those of you that are listening in through the phone line only and are not also logged in online, we ask that you please mute your phones using your own phone's muting feature. And we ask that you help us avoid any disruptions during the presentation by muting your phones now. Time has been scheduled to allow for questions and answers at the end of today's presentation. Please feel free to type your questions as you think of them during the presentation so that you have enough time to submit your question to us. If you don't see the question box area on your screen, just know you can access this menu you can access this feature from the menu that's at the top of your screen. You want to look for the orange box with the white arrow, which will expand and collapse the console. We'll be able to see the questions and we'll compile them throughout the presentation, and we'll read them aloud for our presenter to respond to them verbally for everyone's benefit once the session is open for questions. And with those announcements out of the way, we're going to go ahead and we're going to start our recording. And now I'd like to officially welcome you to today's presentation on value-based purchasing score improvement, and this is session number 4 of 6, which will be a second installment regarding home health caps, and it's going to be speaking about specific care issues. And it's my pleasure to introduce our speaker for today. Melinda Gabori is co-founder and Chief Executive Officer of Healthcare Provider Solutions. Melinda and Mark Cannon founded the company in April of 2001 to provide financial, reimbursement, billing, and clinical consulting to the home health and hospice industries. Melinda has over 19 years of experience in Medicare home health reimbursement and has remained on the cutting edge of Medicare PPS since the regulation's inception. She has helped her clients bridge the gap between clinical and financial issues and has been a seminar and webcast presenter for 20-plus state home care associations. And she's also the author of the Home Health Pocket Guide to Oasis C. And with that, Melinda, I'd love to welcome you and turn things over to you.
Thanks so much. Welcome, everyone. We are going to jump right in to the second part of the HHCAPS presentation today, where we're going to discuss specific care issues, the overall rating of the agency, as well as recommending the agency. And we'll talk about some of the intricacies and some of the interesting pieces of data that we can extrapolate from just what's being reported on the Home Health Compare website in regards to those as well. So we're going to start with the questions from the actual questionnaire that go into the calculation of specific care issues. Questions 3, 4, and 5 are on this page, and then we have 10, 12, 13, and 14 on the next screen. These questions all have to do with specific care issues with the patient. When you first started getting home care from this agency, did someone from the agency talk with you about how to set up your home or so you can move around safely? And so it's an obvious thing that for most home health agencies, when the clinician goes out to do that initial start of care, they're reviewing moving that rug out of the patient walkway, some hiding it in the closet, et cetera. The problem we have experienced in just having questions being asked from clinicians in the field, we do all that, and then we go back and ask them, have you been, has safety been discussed with you? And they're like, no. And so what to do at that point. And so I think one of the key factors here, as I most likely mentioned in the first session, specific to HHCAPS, we need to use the words within this questionnaire in our daily care of the patient. So when we're discussing moving that throw rug out of the patient's walkway between the living room and kitchen, we're saying to them, this rug needs to be moved so that you can safely ambulate, or for safety purposes to keep you from tripping, etc. We have to integrate the words in this document or in this questionnaire into, again, our conversation and communication with the patients on an ongoing basis, so that when they get these questionnaires, those words trigger in their minds, oh, of course they talked to me about safety. They talked to me about the safety of moving that rug out of the way so that I wouldn't trip over it. They talked to me about the safety of using my four-wheel walker when I ambulate to the bathroom, the grab bars when I'm getting in and out of the shower, etc. But in all context of discussion with that patient regarding those things, we need to use the word safety or safely. One of the number one issues we have with documentation on OASIS is clinicians not taking the safety factor into account when determining what the responses to the ADL section questions should be on the OASIS. So it may be that it's not just the patient that is not getting that feel of safety being the reason for being there. It may be that our clinicians are not thinking through that either. And so safety's got to be on everybody's mind, and it needs to be communicated using that very word when we have discussions about things that need to be changed, altered, etc., in the patient's home or in what they are practicing at home, so they understand that you are discussing safety to them or with them. Question number 4, when you started getting home health care from this agency, did someone from the agency talk with you about all of your prescription over-the-counter medicines you were taking? So this question and question number 5 kind of go together, but they are two separate questions in the sense that number 4 says, did the agency talk to you about all of the prescription and over-the-counter medications? Question 5 says, did someone from the agency ask you to see all of the medications and prescription and over-the-counter medications? So those two questions, you know, obviously go together, and they may even be in the opposite order of what we would do normally. Hopefully, we're asking to see all of their prescriptions and over-the-counter medications that they take, and then, of course, having that conversation with them about those medications. We have to be very intentional about making sure that they understand. So when going into a patient's home, for example, and you see all their medications, or my mother's would have been a gallon Ziploc bag of medications sitting on her nightstand, you asking to see the bag and going through the bag, etc., is not necessarily going to trigger in them that you have specifically asked to see their drugs. You need to have those words again in your conversation. And you don't just take their word for it. You don't just go through the medication profile and say, so are you still taking this? Are you still taking this? Are you still taking this? But ask them to see the actual bottles. It's going to be a shock. And many of you, of course, have already experienced this. But in some of you that may not normally practice that, in asking to see them, you may find things that are a little scary. Two of the same medications, or what I should say is two medications that do technically the same thing in the same place where they're keeping all their other drugs, yet they say, oh, well, I'm not taking that one right now. Well, who's to say they won't accidentally take it? And who's to say because it wasn't on their medication profile that they're not taking it, because what's on their medication profile came from the hospital, but when they went to the hospital, they left 3 bottles of medication at home and didn't take everything with them. So the people in the hospital may not even know that they have these 2 or 3 drugs that they're taking. So there's more ramifications here of not doing a full drug regimen review than simply not getting the appropriate responses on the HHCAPS scores or on the HHCAPS surveys. So we need to make sure that we are, again, intentional about all this stuff. One of the OASIS outcomes is, did all of the, and specific to value-based purchasing, did the patient have a full drug regimen review? So we've had this discussion. We talk about value-based purchasing in the sense that it is not technically a billable skill if you're reviewing medications with the patient unless the medication is new or changed. But you still have to do a full drug regimen review. And then in the case where you're discussing medications, et cetera, with the patient that not necessarily have been changed or are new to the patient, you would obviously be providing another skill in the home at the same time. When you ask the patient to see all of their medications, I would use the words, any prescription medications that you are taking and any medications, supplements, vitamins, et cetera, that you are taking, you did not have to have a prescription for. Things that you could buy over the counter. So you need to get details in that conversation you're having with them and what you're asking for. So again, when they read these questions, they see those trigger words that you've already been using with them when you review their medications, and make sure those are in hand. Now, both of these questions say, when you started getting home care from this agency, did these things happen? I know that you know that at the end of episodes, when you're filling out those discharge, et cetera, OASIS, you're seeing that question about that full drug regimen review and had they been discussed. And so obviously when you first start the patient, you're not necessarily going to get down into the details of each medication that they're taking, interactions, et cetera. And that's most likely going to be spread out over the episode. But I would encourage you, even at discharge or during the discharge planning process of the last few visits, that you revisit all of their medications over the counter, et cetera, having that conversation with them so that it will be fresh on their minds when they receive those surveys, that you indeed have had discussions with them regarding all their medications, and definitely ask to see the medications yourself. Question number 10, in the last 2 months of care, did you and a healthcare provider from this agency talk about pain? We know that we all are going to do, our initial assessment nurses are going to discuss pain with them initially, assess the pain that they may or may not have, show them the pain scale, show them the Wong-Baker's face scale, if that's what we use, and get their information regarding pain as much as you can. I hope you're not just asking questions, but you're also observing the patient in mobility, ambulation, et cetera, to see if you can tell or ask them the question actually when that's happening, and in case they're not necessarily giving you the whole truth and nothing but the truth regarding their pain and mobility. But having said all that, that typically is happening. No one would question that at the point of the start of care or the admission visit. This question asked in the last 2 months of care. So if you had this patient for 2 full episodes, the research episode is where they're asking, did they talk to you about pain? And some of you are probably saying, oh, we do that how's your pain today thing every single visit that we go to. But what I would want to caution you about is in the last few visits, that's what I meant to say, prior to discharging this patient, that you elaborate a little more than just simply saying on a scale of 1 to 10, what's your pain today? And it making it a routine thing that might be put in the back of their minds as routine. And having a little bit more of a discussion with them about the pain, making sure that they're answering the question in all aspects, when they're lying down, when they're standing, when they're walking, when they're getting something to eat, et cetera, et cetera, et cetera. So again, it's more fresh on their minds that you did have that pain conversation with them. So we all know that memory can be a big issue with our patients. And some of your patients, you're probably thinking, Lord help us, because there's no way they're going to remember any of this. And I get that too. And so in some situations, we're really hoping we have caregivers involved in answering these questionnaires. But all you can do is all you can do. But I do want to make sure you hear me say, even if it were a 45-year-old patient, obviously I get, unless they're disability, et cetera, they wouldn't technically be a Medicare patient, but play with me here. My point is, the younger, more vibrant patients that you would see versus the 95-year-old bedbound patient, even those patients that may have it all together and have a mind that works, you know, better than yours even sometimes, that doesn't mean that when they ask this question, when they read this question, and the conversation was back at the very start of care about pain, and because they didn't have a whole lot of pain, there really wasn't any more discussions. If they had any pain at all, there really weren't any more discussions about it. They're not going to answer this question, yes, that you had that conversation with them. So that's really my point. We need to make sure that we are very intentional about all of these items, but making sure, especially the ones that address the last 2 months, if it's a patient that has been with you greater than one 60-day episode, all of this has to have been repeated in the research episode. So the next question, number 12, in the past 2 months, did home health providers from this agency talk with you about the purpose for taking your new or changed medications? The next one asked, in the last 2 months, did the home health providers talk with you about when to take your medications? And then the last one is about side effects. Now, why they had to throw this pain question in the middle of the medication questions, I'm not really sure, but they did. And so the questions before this talked about, did they talk to you about your medications, including over the counter, and did they ask to see them? And then before we get to the question about the purpose, the side effects, and when to take them, we got pain thrown off in the middle of that. And that went from question 5 to 10, so the question 6 through 9. I can't tell you for sure what's in there, but my point is, it's still here. So they're talking about, did they, or they're answering questions, did they talk to you about your prescription medications? Then they get down here and start asking specifics. And so the purpose of the medication, when to take some medication, and of course the side effects of the medication. So I hope that we all get the fact that 2 things. First of all, these questions again are in the last 2 months. The first questions that we addressed about, did they talk to you about your medications and did they ask you to see them, was at the beginning of the home health care. So it says in when you started getting home care from this agency. So that's the first 2 questions. These questions are specific to the last 2 months. Again, just like with the pain item, making sure that we all understand we have got to intentionally address these issues ongoing throughout the care of the patient, especially in the patients that have been restarted. Because if they're restarted, obviously, the last 2 months is not going to include that start of care episode. So when we're talking about the purpose of the medication, I think we need to use that word, because they're going to see that word on the questionnaire, and having not been acclimated, for lack of a better word, into that word being used in context with their prescription medications, they may not necessarily get that you really did do that. So we need to make sure we're using the word purpose. What was the purpose of that medication being prescribed to them? Obviously what it's going to do for them, etc. But using the word purpose not just having the conversation as to why the physician gave you this prescription, or what diagnosis is this prescription treating, what symptom is this prescription going to make away, and make go away, but what was the purpose in the prescription medications that the physician gave you. So we just need to be intentional about using that word. And the next question, when to take their medications, I think that one's pretty much a given. They're going to get that. And number 14, the last 2 months, did home health providers talk to you about the side effects of these medicines? So we need to use those words, not anything else, or like what symptoms or whatever that you might have if this medication doesn't work well with others. We need to use the word side effects. I think that one's pretty much a given. I don't know that we would so much use the word purpose intentionally, automatically, and that we've been doing that ongoing. Side effects, we probably have been using a lot. When we leave information in the home about the patient's medications, make sure that one of the things you're leaving with them shows the side effects of that medication that they might need to look for, which I'm sure you're probably doing already. But pointing out specifically side effects to them, especially in the written documentation that they'll still have in home. So to recap some of these specific issues that we've discussed, the medication review policy, hopefully you have one internally that basically addresses the fact that every skilled clinician, especially admission staff, have to do a full medication review with the patient, and we need to address, in my mind, we need to address that 2-month situation in making sure that it's an ongoing process of having those intentional discussions about their medication, side effects, etc. Do therapists conduct your start of care comprehensive assessments, and if so, do they follow the medication review policy, or do you have someone else get involved, especially if there's high risk medications that therapists don't typically deal with? We are 100% advocates of the fact that therapists are fully qualified to complete OASIS and conduct start of care visits and start of care comprehensive assessments, including medications. But there are some that may not be as familiar with or as comfortable with addressing medications as clinicians may be. The OASIS regulations are very clear that there is allowance for the medications being addressed by a clinician outside of the therapist when therapists are the ones that are there. So having said all that, we need just to make sure that if therapists are doing the starts of care, that they are fully prepared to have the medication discussions such as we've just discussed, and that they are going to ongoing throughout that episode make sure that the medication situation is dealt with, so that they're asking if they have any new medications they need to talk about. The side effects have to be discussed, of course. The purpose of the medication still has to be discussed. And again, if you're going to bring clinicians into the picture, and even if it's over the phone, then it's allowed, but just make sure that whatever is occurring with those therapy patients is occurring across the board, and that we know what is happening. Are clinicians truly spending, okay, let's go back to number 3. Do you automatically request orders to teach new or changed medications if you don't already have those orders? So my question is, when you go into the home, you discover that patient came home from the hospital, 2 of their medications, which you may not have realized prior to, you may not have gotten a history and physical from the hospital, 2 of their medications are brand new, and the original order simply said skilled nurse to eval and treat. Are we intentionally asking for the order from the physician to teach those new or changed medications? We need to make sure we are definitely doing that. Are clinicians truly spending time reviewing and getting feedback from patients, or just distributing paperwork regarding their medications? So while I made reference a few minutes ago to those documents that you may be leaving in the homes of the patient that are specific to their new medications or changed medications, or even any of their medications that show side effects, etc., my point here is you can't just leave the paperwork and tell them this is about your medications and you can read them later. You need to have the conversations with the patients. Go through the paperwork with them so that they understand where to look for the side effects and signs and symptoms if they're having a reaction, those types of things. So you need to go through that paperwork with them if you're going to leave it, or make sure that you have done that with a caregiver, et cetera, if the patient isn't capable of doing that. What are the agency pain assessment protocols, and more importantly, the implementation of improvement in pain if, of course, pain exists? So we don't want to hold ourselves to just asking about the patient's pain, but truly assessing the pain. My mother, I know I go back to her a lot, but she's provided me multiple examples. My mother had pain the majority of her adult life. From one thing to another. She had arthritis. She had neuropathy in her feet from diabetes. I could go on and on. But if you ask her any given day of the week how she was doing today, oh, I'm fine. And she got to the point where the pain was just a normal part of her life. And that's just how it was. And so to tell you that she was having a really bad day, she didn't feel like she was having a really bad day. And so you have to be intentional about dragging, in some cases, dragging that information out of the patient. And in many cases, you will not necessarily get the right response. And so having that patient to get up for you and walk or ambulate to the bathroom where they're going to transfer on and off the toilet, get in and out of the shower if possible, et cetera, is going to help you answer a multitude of the OASIS items. But during that time, it will also help you assess grimacing, moaning and groaning, et cetera, that may be related to more pain than they have been willing to tell you they have in the interview process. So that opened it up the window for further discussion on the pain that the patients may be having. So we need to just make sure we're getting that full assessment, again, not just at the start of care or not just at the recertification of the patient, but that pain needs to be discussed ongoing. Obviously, if they have pain of the kind that you will be able to provide some relief to, therapy, et cetera, that needs to happen. But in the cases of where my mother, another situation with her is that a lot of the pain that my mom had, especially in the later part of her life, was not pain that you really could do anything about, and that nobody was really going to be able to help. But having the conversation with them and maybe providing some information about comfort and things that they could do for that pain throughout the care of the patient, even if you're not specifically treating it, is again going to bring back to their minds those conversations and those comfort measures and even the medications that they may be taking and those conversations that they had with your clinicians, so that hopefully when they get these questionnaires, they're going to be able to answer them such that it reflects that we actually did or were able to meet that need. So on the next slide, we're going to talk about the global item. This one is question number 20. We want to know your rating of your care from the agency's home health providers using 0 to 10, where 0 is the worst home health care possible and 10 is the best home health care possible. So your patients are going to be rating you here from a 0 to 10. When we talk about the pain scale, we say to our patients, so from 0 to 10, how bad is your pain today? Or what would you rank your pain? So we're not necessarily, it's not necessarily going to work in their minds. Hopefully they're not going to get any of this confused, but somebody else brought this up, so I thought I might mention it. And that is, if we tell them we're an 8 in pain, that's not a good thing necessarily. Now, it does obviously show that there's more pain, et cetera. So hopefully there's not going to be any confusion with this 0 to 10 thing and how much they really like you versus pain. but you know, it is what it is. So hopefully they will read the full instructions and understand 10 is the best, and hopefully we're going to be a 10. So one of the questions that I ask when typically teaching about HHCAPS is how many agencies in the room actually believe that your home health agency is a 10? How many of you have full confidence that every day when your field staff leave your office or leave their home to go treat patients in the home that are under your care as an agency, how many of you believe that all those clinicians are 10s in the care that they're providing, in the conversations that they have with their patients, in their abilities to listen to the patients, and their abilities to know the patient's care plan before they get into the home, in their abilities to discuss medications with the patients and make sure that the patients understand the purpose and the side effects and when to take the medications. How many of you have confidence that you have clinicians leaving your office to treat patients that you would score a 10? So I challenge you, especially if you're a director, supervisor, administrator, etc., to answer that question for every clinician that you have going to see patients. And if there are any clinicians that you would not say were a 10, I hope that you're going to say they're an 8, 9, or 10. And if they're not even close to that, something has to happen quick. And that means education, etc. Some things in this service mode that we've been talking as far as HHCAPS are concerned, some of your clinicians, there is no teaching that. I think we discussed in the first part of this about the bull in the china shop. And if you have that employee, that clinician in your office that doesn't even get along with your own staff, how are they going to get along with patients? And so again, I challenge you to ask this question number 20 of each and every individual staff member you have, clinicians in the field, as well as staff members in the office that are going to answer the phone when these patients call, and how many of them can you rate as a 10? If you can't rate them as a 10, what is it that we need to work on? What is it that we need to fix? Because if we don't believe we're a 10, and we don't believe our agency is a 10, we don't believe our clinicians are 10s, there's no way our patients are ever going to believe we're a 10. So this next screen talks about a little bit about just elaborating questions to ask. You know, do we know how our patients feel about us? So one thing that a lot of our clients have done in light of the HHCAPS, some of them had already been doing, is scheduling routine phone calls to new patients especially, and restarted patients, just to ask the question, how was your start of care visit with your nurse today? And this will help you learn a lot about the relationship that your clinicians have already begun to build with the patients, as well as help you identify issues from day one, so that any issues the patient might be frustrated with or upset with or not quite comfortable with, we're able to deal with that in the very beginning. So some of you are thinking, has she lost her mind? And no, I promise you, I have not lost my mind. And it may be that you don't have the capacity, nor do you feel like it is necessary to call every single start of care patient, but I'm telling you, it should be a large percentage. And you need to have those conversations, make those relationships, develop those relationships, and make sure you do understand. When my mother had a start of care visit in home health, I've told this story, and I may have told it even at the winter gathering in Florida. Her home health visit was 45 minutes for the start of care, and my mother never got up out of her recliner. The nurse never asked her to. And so she did not see her ambulate. She did not see her transfer. She has no idea what real pain my mother had, inactivity or movement. She did not ask her to try to get in and out of the shower or on and off the toilet. She did not ask her to lie down in the bed and get up with the new GG mobility question. Of course, that wasn't on the OASIS when my mom was going through this. She did not ask her about how she prepares meals, et cetera, if we're not home, et cetera, et cetera, et cetera. And so, you know where I'm going with the fact that if the clinicians are not all about making this happen, it's simply not going to happen. My mother loved that nurse because of the personal relationships that they developed. However, was she truly addressing her care needs? That becomes the next issue. And we really have to deal with that. But conducting those surveys initially, so if you had called my mom would have said, Shirley's amazing. She's wonderful. I loved her. She's so sweet. Can't wait till she comes back. But then if you ask some pointed questions, did she ask you to transfer on and off the toilet? Did she ask you to show her the kitchen, the bathroom? You know, did she ask you to ambulate with your walker? You know, those kinds of things. If you ask those questions, then you would know, because my mom would have told you, because my mom had no idea that she was supposed to get up out of her chair and do all this stuff for this start of care nurse, because she didn't ask. So it will help you do multiple things. It will help you make sure that you are identifying issues, personal issues maybe between patients and caregivers, but it will also help you identify other issues you might not have thought you had if you ask the patients the right questions. As I asked a few minutes ago, do you truly feel like you're a 10? If you don't feel like you and your staff are a 10, patients are not going to feel like you're a 10. These last two comments are quotes. You treat a disease, you win, you lose. You treat a person, I guarantee you will win, no matter what the outcome. And that was by Patch Adams. And then a quote by Maya Angelou, they may forget your name, but they will never forget how you made them feel. My dad, when he was in hospice, every morning when he woke up, he wanted to know if the goat lady was coming today. My dad's hospice aide she and her husband owned a goat farm. And when the hospice aide was in my father's home, she talked to him about that goat farm and about her goats, and, you know, was very, very personal with my dad, and very, you know, her communication skills with him were amazing. And he loved knowing that she was coming to see him. And so that to me, he had no idea what her name was, had absolutely no idea. He called her the goat lady. So he had no idea what her name was, but he knew how she made him feel. And when your patients get those surveys, they're going to remember how your clinicians made you feel. One other thing I want to point out before we leave this and talk about some other things is making sure that when we talk about the questionnaire, in the first session, we talked about making your staff or having your staff sit down and go through all these questions and make sure your staff are familiar with the questionnaire and what the patients are going to be asked. That has to include your home health aides. It has to include the aides. Because again, as in my illustration a moment ago, yes, it was a hospice aide, but it would have been no different. If that lady had worked for home health, she would have been the same way. So the aides are very, very personally involved with the patients, especially the ones that are helping with showers and baths, et cetera. And so the aide needs to understand the questions and the content and know what these patients are going to be asked when they get those surveys. Outstanding service, we're not going to go through each and every line on here, but basically outstanding service is not the norm in our country today. And I don't mean that just from a home health standpoint. There's restaurants that you go into and you're thinking, you've got to be kidding me. There's one that we've given at least 5 chances now, and we drive 25 more miles down the road, or at least 20 more miles down the road to go to the same brand of restaurant, but we refuse to go to the one 20 miles closer, simply because the service is horrific and they won't do anything about it. So it's not the norm. And if we want to be reflected as providing outstanding service on these HHCAPS surveys, we have to provide the outstanding service to our patients. So thoughts for that. The HEAT model. I found this. I thought it was great. These are for those patients that call and or caregivers of patients that call and are extremely upset about something. You have to have someone within your office that has the ability to deal with that, and they're not a hothead themselves. They're not the person that if you want to light somebody's fire, you go to that person. That's not the one you want answering these calls. And so obviously this may not just be a call. It may be a patient where the nurse or the therapist has gone into the home and the patient is going off and gets upset. So this is just a really four-step approach to handling those types of situations. And the agencies that handle the hothead situations the best are going to be the agencies that come out most successfully with these surveys. If we leave situations with patients in a heated setting or heated situation and we do not reconcile their problems, they're going to be the ones that answer the surveys, and they're never going to be good. So the first part of the HEAT model, the H for hear them out, allow them to blow their stack. Obviously, I'm not suggesting that we allow them to abuse the person that is listening to this. You know, cursing and all that, I get it's going to happen, but I'm not suggesting that the person listening has to listen to verbal abuse. But you need to let them get out of their system what they're trying to tell you is the problem. And make sure you say, paraphrasing is one thing. So you're repeating back to them what they've said to you is the problem, which is a very good method, not just in the HEAT model, but even in instruction and care of the patient, just to make sure that that triggers in their mind that you really heard them when you're responding to them or repeating to them what they've just said to you. Empathize, of course. When you say, I understand, you really don't understand most of the time. I am the world's worst at using that phrase. But, you know, seriously, do you really understand what they truly feel like right now? And most likely you don't. If you're the agency listening to a patient, you probably don't truly understand. So one of the suggestions they have here with empathize is, no wonder you called. We understand why you're upset. We get that there is a problem, but we need to make this right, and we need to figure out what we can do to fix the problem. So simply telling them, I mean, some people, by saying to them, I understand, is going to make them even madder because they know you don't truly understand the situation that they are in. But you do need to. And obviously, I get that you're going to have those patients that call and are mad about something all the time. I'm hoping those are the exception to the rule. And while you have to figure out how to deal with those patients, these patients or these situations we're discussing now are going to be those people that get really upset about something, but they can be brought back down to reality as long as their problem is addressed. The worst situations from a heated standpoint are going to be the ones where they have already told someone the problem and nobody did anything about it. And then they told somebody else the problem and nobody did anything about it. And we're now on the third or fourth rung of this with nobody having done anything about it. So we have to respond. I'm not saying that we can always give the patient or caregiver what they want, but we have to be able to come up with a compromise and a solution that will make everybody happy and it will work for everyone. So ask is number 3 in the HEAT. Ask more detailed questions if necessary. I want to get you the help that you need, but I really need details here. And so, of course, if you need to get more detail from the patient, you need to ask that detail. Make sure that you have everything that you need from them in order to completely reconcile the problem that they're calling about. Last point, take action if action is required. Be careful not to overcommit, meaning don't tell them you're going to do something that you know you cannot do. Don't tell them that we're going to make sure that caregiver never comes to your home again if that's the only caregiver in that discipline you have available for the next 3 weeks. So the point being, don't commit to something that you know you're not going to be able to do or that you're not even sure you're going to be able to do. You may have to say, I'm going to check into this and call you back. But you don't say, I'm going to call you back tomorrow, or I'm going to call you back by 3 o'clock today, and don't call them back for 3 or 4 days. But don't make commitments during that conversation that you know you cannot hold up to, because that's going to make the situation even worse. So improving agency scores is sharing the results from your HHCAPS scores, I hope, is a given, meaning that you're already doing that and that you know you shouldn't do that. Engage your staff in improvement, and all staff. That's when I reference all staff, of course, I'm including your home health aides. Make sure that they have that copy of that questionnaire and that you go through the impact of all this. You need to be very deliberate and focused. If you've ever had complaints about any staff member, you need to deal with that complaint, no matter how many years they've been there, or how good you think they are, or how many good how much good feedback you have received from other patients about that clinician. If you get a complaint, you have to follow up on it. Develop standard scripts and behaviors. When we say scripts, I think you have to be a little careful there. As you know, as we talked about in the first of this HHCAPS series webinar, we talked about the fact that you cannot share the survey with the patients. You can't even technically use full phrases or full questions from the questionnaire in any marketing materials, documentation, etc. But those key words, as we've already talked about, you can pull out. We've done some work with agencies where they have created buttons for their clinicians to wear, and the buttons will have a key word on it, like purpose, for example. If you use the word purpose on a button and the clinician or the patient says purpose, what's that about? What's that button about? And then having that conversation with them about what the word purpose really means, and the purpose of their medications, specifically addressing medications with them in that context. And so any of the key words that you think they might have issue with, one of those being recommend. I didn't put the actual question in here about from the questionnaire about whether or not the agency or the patient would recommend your agency to another patient. We, as an industry, multiple times I've had this conversation with states and associations in different states. We feel like that question gets a lower score because the question itself, or the word recommend, is misunderstood, and that maybe the patient thinks they're going to have to do something, another survey or whatever, to recommend your agency. And so we have some agencies walking around with buttons that say the word recommend on it, and we have that conversation, or asking your patients, is there a restaurant in the area that you would recommend I go to eat lunch for, or lunch at? Having the conversations with the patient about their neighbor, you know, if they ever needed home health, would you recommend them to us? You know, that kind of thing, just conversation around those key words. And so that's what it means when it says develop those standard scripts, behavior standards being one of the things related to making sure medication reviews are being done on all patients for all medications, including over-the-counter, et cetera. Don't forget to identify processes that create problems and correct them. So one of the things we talked about in the first couple, developing a process for who answers the phone when there's a problem being called in by a patient, and what the response time is in which we promise to call the patients back. When do your clinicians call the patient to tell them they're coming for the visit and what time they're coming? How consistent is that? Do you have clinicians that are not calling the patients ahead of time when really they probably should? Do you have a standard practice, process, policy for all that key stuff that could affect this together? Call patients' families after admission and periodically, which is what we talked about earlier, hold managers and staff accountable. So from the Home Health Compare website, I have taken two particular questions using the graph, as you can see, and it shows 3 random agencies from the state of Florida. Have no idea who these people are. I literally went through the Home Health Compare page, went to like page 10 and page 12. I mean, this is random numbers. It really wasn't the page numbers I used, and clicked 3 different agencies throughout my options and then did this report. So we have 3 agencies, and then the comparison to the state numbers and to the nation. And so I just copied this. This is from through June of 2016 reporting year that's currently found on the Home Health Compare website. So in the question, this particular question is, how do patients rate the overall care from the home health agency? So the state of Florida, 85% are positive overall ratings, 84% of the nation, and then these 3 agencies are 86%, 88%, and 86%. And I think these footnotes, footnote 11, I mean less than 100 responses were received in the calculation of that number. But then this is the one that concerns me. We go from an overall rating to reasonably high, and then we get to, would the patient recommend the agency to friends and family? And all of those numbers dropped, including Florida and the nation. And so again, it has to boil down to, if the patient is giving us 8s, 9s, and 10s on our overall rating, why would they not recommend us to another friend or family? Again, I think it all boils down to that one word, recommend, and they don't fully understand what that means, and they don't understand that they're not expected to do anything additionally to make that happen. So data, of course, is a huge thing that we all have to use, and we all need to analyze, and we all need to figure out what kind of data we want or we need. Many of you may have software systems that give you all the data you could ever dream of in the form of your home health software, or possibly a third-party vendor such as SHP or OCS or PPS Plus, where they analyze OASIS data and give you reports. Some of them also have HHCAPS data. Whoever your vendor is can probably give you that data, but you need to look at as much data as you can get your hands on, making sure you understand from whoever created the data, software system, etc., where exactly it came from, as much data as you can get by patient. Risk assessments provide data points to help deliver consistency, predictable care, and best outcomes. So that's in reference to the fact that many of the OASIS questions, etc., are risk adjusted and do help take out some of the unpredictability. Tracking individuals in real time for data correction or course correction, meaning you have those outlier patients that you are getting reports from. If there's any way for you to get outcomes specific to patients, that is amazing. And obviously, making phone calls and getting input is one way, of course, to get real-time data from your patients. And of course, anything and everything you can get from your vendors that are conducting these for you is huge. Identify which patients for investigating outcomes. And outcomes, when we talk about HHCAPS, are a little different. And sometimes you can't get into the patient, but obviously we can get into patients that, from the standpoint of things that the OASIS would reflect, whether or not we're doing medication reviews, would reflect whether or not we addressed high-risk medications with the family or caregiver, would address whether or not we have scored the pain appropriately. Have we done pain assessment risk tools on the OASIS? Did we show improvement in pain? So there's many of these items on the OASIS that may calculate outcomes, etc., that can be used to also drive. Our OASIS doesn't even reflect we're doing this, so why would we think that the patient is going to reflect that we're doing it on an HHCAPS survey? Are we sure patients are happy with our services and understand the importance of the survey? There is nothing anywhere that says you can't tell them they're going to get a survey. It simply says that you cannot give them a copy of the survey, nor can you tell them that your expectation is that that survey is going to have a good response on it, or good information, high ratings, etc. So one of the things that you as an agency need to ask yourself, especially if you're not doing quite so well, Do we have the right vendor? Are we using the right method? The surveys can be sent out via mail, or they can also be done via phone call. I have had different agencies tell me different things work for their patients. I had one tell me that she went to phone calls and she got a huge jump in improvement in the number of responses that she got for the HHCAPS scores, as well as improvement in her scores. But then you have one that says, well, we went to phone calls, and the first, few that they called, we got horrible scores because the patients were upset or mad or whatever, and they were totally willing to vent and weren't going to fill out a mailed form. So different things work for different ones. If what you're doing now doesn't work, you may investigate going to something else. Do you do your own surveys? As I suggested earlier, you might want to be making those phone calls, especially with new patients and recerted patients, to make sure everything's going okay. If you have a new staff member, a new clinical staff member that you're sending out to see patients for the first time alone, you need to be making phone calls to those patients to ensure those staff members appear to be what you thought they were when you sent them out to see those patients for the first time. And not just their relationship with the patient, but the care that they're providing to the patients as well. Do staff members have a plan to ensure that the patient knows about the survey? So have you made it a part of the routine things that they're basically checking off on in their comprehensive assessment, in their discharge planning, in their visits on a routine basis? Is there things in your software systems or paperwork with your clinicians that trigger those clinicians to make those comments about the survey, to remind them, to make sure that they want the patient to be happy, et cetera? And is there anything else we can do for you today? Have we provided, all the help that you need? Is there anything we can help you with? Help, I'm saying help so much because help is one of the words. When you called the agency for help or advice, did they respond, and how long did it take them to respond? So integrating those keywords, again, not necessarily on buttons, but in the conversation with the patients from your staff, and of course, making sure that your staff are keeping your patients abreast of the fact that they're going to get a survey. Okay, we're going to go ahead and take questions now. We have a few minutes left.
Okay, Melinda, and while I give everyone a moment to type any questions that they may have, just a reminder to everyone that an evaluation of today's event will pop up on your computer screen as you go to exit the event. So we ask that you please fill that out. And if you have more than one person listening in at your location, we ask that they fill out the paper version of the evaluation form, and you can fax those back to the association that you registered through, or you can send them to HCAP at 850-222-9251. And with that, Melinda, just one question came in so far, and this question just asks for clarification so that they are on the correct page. They want to know, or just ask to clarify, when it comes to informing the patient about the survey, they can inform them that they will receive a survey, but they can't go through the survey questions with them, and they cannot provide them with a copy of the survey. Is that correct?
That is correct. They cannot give them a copy. They cannot even give them a question in its form as it is on the survey. Even, like read a question to them and say, this is a sample question, or exactly. You can't use full phrases, full questions. You cannot give them a copy of the survey. You're definitely expected to inform them that a survey is coming, and that you hope they will complete it, but you can't even lead them as far as telling them you hope that it's going to be a good survey, or we're expecting a 100%, or whatever, but you definitely are expected to inform them that they will be receiving one. And I would also make sure that you're informing them of what format they will receive it. So if you're currently paying for the surveyor to conduct phone calls, and it's 100% phone calls, then they need to know that it's going to be a phone call, not a piece of paper coming in the mail. But obviously, if you're mailing surveys, they need to know to watch for it in the mail.
Okay, very good. And with that, Melinda, I'm not seeing any other questions, so I'll just turn it over to you for your final thoughts.
Okay, just to wrap up this session, for both the last two, just emphasizing how you need to get all your staff together. They all need to have a copy of this survey. You really need to go through it question by question, make sure they understand the full ramifications. But as administrators and directors, that some of you may be, or supervisors, I would go through that survey and pick out the key words that your staff may or may not be currently using on a day-to-day basis with your patients, but emphasize how important it is that they do use those key words with your patients, especially words like help, advice, purpose, and safety. So that's all I have today. Thank you all for joining us.
Thanks so much, Melinda, to you and to Healthcare Provider Solutions, and thank you to all the attendees for joining us. As always, we appreciate you supporting these educational offerings, and we'll talk to you during the next session. Take care and have a great day.